Hi, welcome. Let's discuss about ectopic pregnancy. Ectopic pregnancies are the pregnancies which happens outside the uterus, which implanted outside the uterus. The incidence of ectopic pregnancies are 1 to 2% of all the pregnancies which happen, and with assisted reproductive techniques, the incidence is as high as 5%. After one ectopic, repeated ectopic can be 15%, and after two ectopic, the incidence can be as high as 30%. And what are the causes of ectopic pregnancies? It could be pelvic inflammatory disease, or previous ectopic pregnancy, or patients who undergo infertility treatment, or if they use progesterone pills or IUCD, and there is history of tubal surgeries, history of endometriosis. So patient undergoes infertility treatment by in vitro fertilization, and she is pregnant, and she comes to you with circulatory collapse. Think of ectopic pregnancy first, because infertility treatment directly promotes to the increase in incidence of ectopic pregnancy. So these are the causes of ectopic pregnancy. And what is the most common site of ectopic pregnancy? Most common site of ectopic pregnancy is the tube, and in the tube most common is ampulla. So the time of rupture of the tube is important. Ampullary is the most common, and it will rupture between 6 to 8 weeks, and ischemic will rupture between 4 to 6 weeks, and conval is also known as interstitial. This will rupture the last. It will rupture between 12 to 16 weeks. The patient has ectopic pregnancy, and how does the ectopic continue for some time before it rupture? So this ectopic here, it has its own trophoblast which is making HCG, and which is also making the corpus luteum, and which is making the progesterone. Progesterone is the one maintaining the pregnancy. So what is the fate of ectopic pregnancy? So it should not be the rupture of the tube, not always the rupture of the tube. The fate of ectopic pregnancy is embryo degeneration because of vascular insufficiency. If the ectopic becomes too big for the tube, the distended tube cannot give enough blood supply anymore, and so with the distension, the embryo dies, HCG reduces, corpus luteum dies, progesterone also reduces, and the endometrium sheds. So patient comes with bleeding. So vascular insufficiency is the most common termination of ectopic pregnancy. Termination of ectopic pregnancy can occur by vascular insufficiency, is the most common. It will result in bleeding, shedding of decidual cast, and termination of pregnancy can occur by tubal abortion or rupture of the tube. So what are the clinical presentations? The most common clinical presentation would be pain abdomen, there can be vaginal bleeding, and there can be syncopal attacks. The blackouts. And what are the signs? Patient might have shock, and they can have hemoperitoneum. Hemoperitoneum, you can say the Cullen sign and Turner sign. Cullen sign is the periumbilical bruising because of blood in the abdomen. So C for center of the abdomen. And Turner sign is the bruising in the flank sides of the abdomen. So Cullen sign in the center of the abdomen, the bluish thing, and Turner sign in the sides of the abdomen due to the blood. And the another sign would be abdominal distension. So what you can do in abdominal distension is resuscitation, then plan for surgery. They will ask like what you will do first. The first thing is resuscitation, then you plan for surgery. For ruptured ectopic pregnancy, do laparotomy. You can do laparoscopy. Do this in a stable patient. Don't do this in shock patients. For ruptured ectopic pregnancy, do laparotomy or you can do laparoscopy in stable patients. Don't do this in shock patients. So the tube is ruptured here. There is a lot of blood here. You put a clamp here, not here or here. You put a clamp here and do total salpingectomy. It should not be segmental or partial salpingectomy. It should be total salpingectomy. For unruptured ectopic pregnancy, if you diagnosed it earlier, try to save the tube. If a patient has children, 2 children, and it's okay, you can do salpingectomy, total salpingectomy, but try to save the tube if the patient has no children. And how will you save the tube? By doing linear salpingostomy. You make an incision on the bulge of the ectopic and take out the baby. So this is a linear salpingostomy, and you can do resection and reanastomosis. Medical management would be, you can kill the baby by giving methotrexate or actinomycin or potassium chloride. How do you decide between medical management or surgical management? So if the HCG levels less than 5,000 international units, you can go for medical management. And if the HCG levels more than 5,000 international units, you can go for surgical management. And for the sac size, 3.5 centimeter, less than 3.5 centimeter, medical management, and more than 3.5 centimeter, surgical management. Some book says 4 centimeter, less than 4 or more than 4. And cardiac activity, if the cardiac activity is absent, you can go for medical management, and if the cardiac activity present, you can go for surgical management. For example, sac size is 5 centimeter with the cardiac activity, you can do total salpingectomy. How will you do the early diagnosis? By doing transvaginal sonography or transabdominal sonography. You can see 1 week ahead in the transvaginal sonography for the sac size and cardiac activity. In transvaginal sonography, you can see the sac in 4+ weeks, and you can hear the cardiac activity in 5+ weeks. You can see the sac in 5+ weeks in transabdominal sonography and cardiac activity 6+ weeks. What do you mean by 4 weeks and 3 days? Which week is running is 5th week. So transvaginal sonography is the best way of early diagnosis of ectopic pregnancy. And in 2/3 of patients, HCG value helps. So HCG values doubles in 2 days in normal pregnancy, and it doubles in 5 to 7 days in ectopic pregnancy. Why? Because in ectopic pregnancy, HCG is made from the tube, right? And blood supply of the tube is poor, so it takes time for the HCG to be made. And also, you can diagnose it from the serum progesterone levels. If serum progesterone levels are less than 5 nanogram per deciliter, it is missed abortion. Or ectopic pregnancy. And if serum progesterone levels are more than 25 nanogram per deciliter, you call it normal pregnancy. So these values are important. HCG levels doubles in 2 days is normal pregnancy, and serum progesterone levels more than 25 nanogram per deciliter is normal pregnancy. And what is the discriminatory line? Discriminatory line is the must-see sac. You should see the sac in transvaginal ultrasound. HCG levels of more than, if the HCG levels are more than 1500, you should see the sac in transvaginal sonography. And if the HCG levels are more than 6500, you should see the sac in transabdominal sonography. Other than the tube, ectopic pregnancies can happen in abdomen or ovary or cervix. Abdomen is the rarest. However, the only ectopic will go to full term is abdominal ectopic. And how do you take out the baby in abdominal ectopic is by doing laparotomy. And don't even touch the placenta inside it, stuck to the post-abdominal wall. So leave the placenta, don't even touch it, because the patient will bleed to death. So you, after delivery, you give methotrexate or actinomycin to degenerate the placenta. And that's all, guys. Thank you for watching and keep supporting